Channel. In this video I will discuss amyloidosis. So amyloidosis is a group of disorders that is characterized by extracellular deposition of amyloid. What is amyloid? It is insoluble fibrillar protein and it deposits in various tissues and organs like in heart, also in the brain, and disrupt their function. So what are the types of amyloidosis? Amyloidosis has two main types. First one is systemic and the next one is localized. So systemic is further subdivided into different categories like AL, that is primary amyloidosis. In this case there are deposition of the light chains and is mostly associated with plasma cell dyscrasias like multiple myeloma. In multiple myeloma, monoclonal immunoglobulins, that are paraproteins, deposit in the different parts of the body and lead to this primary amyloidosis, that is AL amyloidosis or light chain amyloidosis. Then we have secondary form, that is AA amyloidosis. It is seen in chronic inflammatory conditions like rheumatoid arthritis, and actually this amyloid is acute phase reactant that is seen in these chronic inflammatory disorders like TB, IBD, rheumatoid arthritis or any other chronic illnesses. Then we have hereditary or familial, that is transthyretin mutations, ATTR. Transthyretin mutations lead to the deposition of amyloid in the body. And then senile systemic amyloidosis. In case of senile systemic amyloidosis, there is wild type transthyretin deposition, especially in the elderly patients. Now next one is localized amyloidosis. For example, when there is a deposition of this amyloid in the islet cells, it is leading to type 2 diabetes mellitus. Then we have cerebral. The most famous amyloidosis is Alzheimer's disease, in which you know that A beta amyloid deposits in the central nervous system, that is in the brain. Then we have endocrine tumors, for example with medullary thyroid carcinoma, leading to the deposition of amyloid in the thyroid gland. So we have different localized amyloidosis, for example islet amyloidosis, Alzheimer's disease and endocrine tumors leading to amyloidosis in different glands of the body. Pathogenesis. Actually there is misfolded precursor proteins. These lead to development of beta pleated sheet fibrils and these are resistant to proteolysis. They cannot be degraded and therefore when they cannot be degraded, accumulate extracellularly, and when it deposits inside the organs, it leads to organ dysfunction. Organs that are commonly affected are kidney. In kidney, when it deposits, leads to nephrotic syndrome, loss of protein in the urine more than 3.5 gram per day, and it leads to chronic kidney disease. In heart, it leads to restrictive cardiomyopathy. When there is restrictive cardiomyopathy, mostly right heart dysfunction occurs, and also the patients are prone to arrhythmias. Then there can be damage to liver and spleen, leading to hepatomegaly, splenomegaly, liver dysfunction, and nervous system is also affected. Peripheral nervous system is when affected, then it leads to carpal tunnel syndrome in most of the cases. Autonomic neuropathy can also be seen and peripheral neuropathy can also be seen. Gastrointestinal tract is when affected, it leads to malabsorption and, as I have told you, hepatosplenomegaly. What are the features with which patient presents to us? Patient presents with fatigue and weight loss when there is systemic amyloidosis. When kidneys are affected, it leads to proteinuria, that is I have told you nephrotic syndrome, and it leads to edema and chronic kidney disease. When heart is involved, then it leads to heart failure with preserved ejection fraction. Ejection fraction is more than 50%. It leads to arrhythmias. It can lead to thickened ventricular walls, and mostly right heart is affected in case of this restrictive cardiomyopathy. So heart failure with reduced preserved ejection fraction, not reduced. Then neurological features, carpal tunnel syndrome as I have told you, and peripheral neuropathy. Macroglossia, enlarged tongue, and periorbital purpura are also seen in case of light chain amyloidosis. How will you diagnose this condition? You will do biopsy and use this Congo red stain. It leads to apple green birefringence on polarized light microscopy. So these fibrils appear apple green birefringence on Congo red stain on polarized light microscopy. What are the sites from which biopsy can be taken? Abdominal fat pad, rectum, kidney or bone marrow. But most commonly we take the biopsy from abdominal fat pad. But if it is not diagnostic, then we can do biopsy from the involved organs, for example kidneys. We can also do immunohistochemistry and mass spectrometry for differentiating the different types of amyloidosis. What are the lab tests? Serum and urine protein electrophoresis free light chains are detected for AL, that is, in case of plasma cell myeloma or multiple myeloma, we do serum protein electrophoresis and urine protein electrophoresis. Imaging, for example, cardiac MRI is done that helps us diagnose cardiac amyloidosis that leads to restrictive cardiomyopathy. Treatment. In case of AL amyloidosis, chemotherapy including bortezomib, cyclophosphamide, dexamethasone, thalidomide and lenalidomide etc. that are used in plasma cell myeloma are mostly used in AL amyloidosis. Autologous stem cell transplantation is also an option in case of plasma cell myeloma that is leading to AL amyloidosis. In case of AL amyloidosis, you have to treat the underlying disorder. For example, you have rheumatoid arthritis, then you should treat this rheumatoid arthritis. If you have IBD, then you have to treat the IBD with steroids, and IBD is treated with steroids and mesalazine. Then if you have hereditary or senile amyloidosis, then for this tafamidis, patisiran and liver transplant for hereditary amyloidosis can be done. Supportive treatments are also needed. For example, diuretics are needed when you have heart failure and when you have nephrotic syndrome. For these conditions, you can use diuretics, dialysis for chronic kidney disease, anticoagulation, pacemakers as needed, because pacemakers are required when there is cardiomyopathy, and this cardiomyopathy can lead to arrhythmias. Therefore, pacemakers may be required. Prognosis. It depends on the type and organ involvement. For example, if there is cardiac involvement, it has poor prognosis. Median survival is when light chain amyloidosis is untreated, there is median survival of almost equal to 1 to 2 years. With the treatment, you can say that it is more than 4 to 5 years. When there is inflammatory amyloidosis, AA amyloidosis, the inflammation is when controlled, then outcomes are better. And this hereditary transthyretin amyloidosis, it is slowly progressive and it has slightly better outcomes, but it can also lead to early mortality.